Welcome to today's Explainer. We're diving into a medical mystery that is fascinating and, frankly, absolutely terrifying: acute pancreatitis. We're going to examine exactly what happens when one of our body's most essential organs suddenly goes rogue, literally turning its own powerful chemical weapons against itself. It's a high-stakes physiological crisis, and understanding how it unfolds is crucial. Okay, let's dive into this and get grounded visually. Take a look at exactly where the pancreas sits. It's tucked right there behind the stomach, intimately connected to the gallbladder, the bile ducts, and the duodenum. It basically sits at a major crossroads of our digestive system. Keep this anatomy in mind as we go, because when things go wrong here, the collateral damage to the surrounding neighborhood is immense. So here is our roadmap for today. We'll be looking at the healthy pancreas, how the pancreas eats itself, spotting the symptoms, diagnosing the damage, and finally, severe systemic complications. All right, starting with Section 1, the healthy pancreas. When things are working normally, the healthy pancreas plays a dual, life-sustaining role. It's essentially a powerhouse factory with two huge jobs. First, you've got its exocrine function, producing potent digestive enzymes delivered straight into the duodenum to break down the nutrients we eat. Second is its endocrine function, producing insulin for glucose metabolism to keep our blood sugar in check. It's a beautifully balanced system. Which brings us to Section 2, the pancreas eats itself. And this brilliantly illustrates the stark, terrifying contrast between health and disease. Normally, you have this unobstructed flow of enzymes traveling safely down the pancreatic duct and into the duodenum where they belong. But then, a crisis hits. The flow is blocked, the tissue becomes fiercely inflamed, and all those highly active enzymes get trapped inside the organ itself. This leads us to the defining mechanism of acute pancreatitis: autodigestion. It's an inflammatory disorder where the pancreas quite literally self-destructs. The ultimate irony here is that the body's very own digestive tools, the enzymes meant to break down your lunch, turn around and attack their source. They start digesting the pancreatic tissue itself instead of the nutrients in your gut. So, what villains actually cause this obstruction in the first place? Well, the two major culprits are alcohol abuse and gallstones. Alcohol is notoriously toxic here because it causes swelling or edema in the pancreas that can physically obstruct the enzyme outflow. Gallstones can migrate from the gallbladder, wedge into the common bile duct, and create a hard physical block. Interestingly enough, in about 30% of cases, the exact cause remains completely unknown. The rest are usually attributed to rare triggers like autoimmune disorders, cystic fibrosis, certain meds, or even high triglycerides. Let's move to Section 3, spotting the symptoms. Now, the pain we're looking at here is highly specific. We aren't talking about a mild stomachache. This is an abrupt, continuous, severe pain in the epigastric region, the upper middle abdomen, that often radiates straight through to the back. And here is a fascinating diagnostic clue. Patients will tell you the pain is way worse when they lie flat, and they actually find relief simply by sitting up and leaning forward. Often, this whole agonizing episode kicks off right after a heavy, fatty meal or a binge of alcohol. Beyond just the pain, the body gives us some vivid physical alarm bells. You might see Cullen's sign, which is superficial edema and bruising in the fatty tissue right around the belly button. Or you might see Turner's sign, which is bruising along the flanks. And let's be clear, these aren't just simple bruises. These signs scream retroperitoneal hemorrhage. They're telling us that the severe inflammation and autodigestion are actually causing bleeding behind the peritoneum, and it's seeping all the way into the skin. Another critical thing to look for are Trousseau's and Chevos-Vostek signs. Now, why are we checking for muscle spasms? Because as the pancreas goes through fat necrosis from being digested, that dead fatty tissue actually binds up calcium from the bloodstream. That causes a dangerous systemic drop in calcium known as hypocalcemia. So those distinct muscle twitches you see in the face or the arm during these tests, they are a direct, visible consequence of that internal tissue death. Section 4, diagnosing the damage. To confirm what's happening, we look at a crucial detective timeline of enzyme markers in the blood. Amylase is your early warning system. It rises super fast, within 2 to 12 hours of symptom onset, but it also normalizes quickly, typically within 3 to 4 days. Lipase, on the other hand, is your reliable long-term witness. It peaks around 24 hours, but stays elevated for a solid 7 to 14 days. This distinction is absolutely pivotal for clinicians trying to diagnose someone who maybe waited a few days before coming into the hospital.
Alongside the blood work, we deploy an arsenal of imaging tools to map out the battlefield. Ultrasounds are incredibly useful for spotting physical culprits like gallstones. CT scans zoom out to give us a much broader view of the damage, pointing out pancreatic enlargement, dangerous fluid collections, and areas of dead necrotic tissue. Finally, an ERCP, combining endoscopy and x-rays, lets doctors get right in there to visualize and sometimes even treat specific problems directly within the bile and pancreatic ducts.
Finally, Section 5, Severe Systemic Complications. So, the crucial point here, the real critical danger, lies in hypovolemia. The intense inflammation causes extreme vasodilation and a massive shift of fluid completely out of the blood vessels and right into the abdominal cavity. We call this third spacing. This leads to severe ascites. But what's worse is that by pulling so much fluid out of the vascular system, it essentially starves the cardiovascular system. Blood pressure drops dangerously low, forcing the heart to race in tachycardia, actively pushing the patient toward hypovolemic shock.
And watch how this builds into an escalating systemic threat timeline. Just 24 hours after onset, a patient can rapidly deteriorate into hypotension, shock, and multiple organ failure, particularly the kidneys, which are just totally starved of blood flow at that point. And if they survive that initial insult, well, the danger isn't over. Between 3 to 7 days after onset, the systemic inflammation can attack the lungs, causing ARDS, or acute respiratory distress syndrome.
Which leaves us with this final, truly provocative thought. A huge takeaway here is that acute pancreatitis is technically a reversible process. The pancreas isn't inherently permanently changed if the inflammation resolves. But given how wildly destructive this autodigestion is, how can rapid, aggressive medical intervention in those first crucial hours tip the scales? How do we stop it from being a completely fatal systemic cascade and keep it a localized recovery? It is a literal race against time. Keep that question in mind as you apply this to your own studies. Thanks for joining me for this explainer.